Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
We're here today to talk about our recent publication titled Maxillomandibular Fixation and Understanding the Risks and Benefits of Contemporary Techniques in Adults. Ultimately, there's numerous techniques that achieve maxillomandibular fixation, each with benefits and risks. And it can be a little bit of a challenge to understand, how those risks have evolved, what forms of MMF people are regularly doing, all of that. So we have Alan Johnson and Scott Bevans here with me, Sarah Akkina, to discuss the publication. And I'm curious, Scott and Alan, how did this idea originally develop from your standpoints?
Hi, Sarah. Yeah, so thinking back, this is Scott Bevans. Alan and I actually were on an Academy panel, so our annual Academy meeting about 5 years ago, and we were asked to speak about some of the different techniques for maxillomandibular fixation. And Alan, I don't know if this was your experience, but as we started to dig into that and really analyze the data behind the risks, benefits, and alternatives between the different techniques, it was fairly eye-opening for me. And I think we all develop preferences over the course of our training and experience, but understanding really what the data supported in choosing between those preferences was a very good experience. Subsequently, we went on to do more research and try to do a systematic review and narrative review, and ultimately ended with this publication that we're referring to today.
Agreed, Scott. I similarly was aware of a number of techniques and was minimally aware of some others. And when I dove into literature, wasn't able to find any real definitive guide to choose between them. And I think that really was what motivated us to go on what ended up being a multi-year journey, trying to sort this out and really get a succinct guide together to help our colleagues, and also for us to be able to teach our residents, how to best apply maxillomandibular fixation.
Perfect. So in that vein, what were the most common techniques that this paper reviewed, and what were the advantages and disadvantages, would you say, of them?
We really identified 5 modern techniques that are in common use and are FDA approved. The traditional Eric arch bars that have been around since the 1940s, followed by hybrid arch bars, which have come into popularity over the last decade or so, being introduced around 2012. And there's a number of different versions of those by different manufacturers. IMF screws, or intermaxillary screws, which have actually been around for around 3 to 4 decades. And then more recently, embrasure wires, which are interdental wires. And lastly, dental occlusion ties, also known as mini ties, which have been out since 2017.
And Alan, you have a particular relationship with dental occlusion ties, we should say as well. Is that right?
Correct, yeah. So I conceived of them back in 2012 and helped shepherd them through FDA approval through 2017.
For anyone that's done any work on the FDA approval process, that probably makes you one of the most knowledgeable people about all the different techniques as you're going through the non-inferiority evaluations from the FDA. But yeah, and I think that was a really nice summary. And when we kind of were thinking about these, we sort of broke these techniques up into 3 categories, right? There's the Eric arch bar circumdental based techniques. There's the screw based techniques, and under that we put the IMF screws and the hybrid systems. Hybrid, of course, being a little bit of a hybrid between the screw based technique and the Eric arch bar, and then the intradental techniques, the embrasure wires, and then the dental occlusion ties that Dr. Johnson was referring to.
And overall, knowing the ins and outs of those techniques, what are the major situations in which you might choose the circumdental or kind of arch bar based applications versus the screw and wire based applications?
The really prevailing decision point that rose to the surface as I was working through this with my co-authors here was that any mandible fractures that were really comminuted, or any fractures that needed guiding elastics afterwards, really demanded either traditional Eric arch bars or hybrid arch bars, or in some subset situations, the IMF screws where you could apply the elastics to have guiding elastics. So really, those are the main decision points in our decision tree: is the mandible fracture comminuted and therefore unstable, needing a really robust system like traditional arch bars, or do you anticipate needing guiding elastics because the occlusion is going to be challenging afterwards? If either of those questions are a yes, then you have to go with the more traditional approaches, the more robust approaches. And Scott, what would you add to that?
Yeah, I mean, there's 100 different factors that we evaluated, right, and tried to compare between the different techniques, the time in the OR, the risk of injury actually to the surgical team, the comfort of the patients post-operatively, the cost of the overall technique. But Alan, I totally agree that the foundation of this is you have to be able to create a stable occlusive construct in order to get patients healing. So that's sort of like priority numero uno. Create stable occlusive construct. The more comminuted any fracture is, the more stable your construct is going to have to be. Thus, the need for some lateral tension band. By that I mean some sort of arch bar, sort of lateral tension capability. This is, in my mind, this is a little bit similar to, in general, when we're approaching mandible fractures, for instance, we always say, like, the worse the bone, the bigger the plate, right? The smaller the bone, the bigger the plate, right? So the less native stability there is in that occlusive construct, the more we have to provide with the technique hardware that we're using. A lot of this is a little bit based on the risks of the techniques, and I think I underestimated the risks of especially the screw-based techniques before we really started digging into this. So all hybrid systems, all IMF screws, there is a risk of tooth root injury, which there have been several publications that suggest maybe we underestimate actually the risk of tooth root injury. And in the process of researching that, we also found some really practical techniques in how to reduce our personal injury, especially to the tooth roots, with those screw-based techniques. You don't use a drill, right? If you're gonna place a screw into the maxilla or the mandible, in order to minimize the risk that we actually puncture into a tooth root in apical position, do not pre-drill. Just allow that screw to glance off the tooth roots if it's going between them.
That's great. So that provides a lot of context in terms of, as you said, the algorithm that gets presented in the paper. First, obviously, our priority is clinical stability and fracture stability. And then if you feel that you can achieve that with some of the other techniques, then you can consider, as you mentioned, Scott, some of the, cost and time of application, the associated risks with that application, ease of removal in clinic, dental health, things like that, which the paper also discusses between each technique.
So then with that understanding, there are clearly advantages of the other three approaches, meaning the IMF screws, embrasure wires, and dental occlusion ties. And I think it's most pertinent to say that those techniques are usually a major time savings. You probably are going to, cut 30 to maybe even 60 minutes off the OR time, and you'll probably get even more savings back as you're removing the MMF, potentially in clinic with these other approaches. So I think that's a major hallmark of these other options. The safety profile is much better because you're going to have less sharps risk injury. In addition to that, I think that there is a comfort factor for the patient. I think there's less hardware in the mouth. IMF screws is going to be a much smaller profile than a hybrid, let's say. Embrasure wires are the least invasive of all of them because you can't keep them in post-operatively, so they're only available for intraoperative use. And then dental occlusion ties have a nice low profile, but you can keep them in for up to 3 weeks after surgery. So they're probably the most comfortable of them, although they offer a fair amount less stability than the other options. I'd say, going forward, there's still a large need for additional research to differentiate these techniques. I think that we have an inherent understanding of how comfortable these are or uncomfortable they are for our patients, but to what extent people are suffering from these technologies because they're painful to the gingiva or because their oral hygiene is poor. I mean, those are things that I think we can still quantify in future years, and I think there's a fair amount of research that could still be done.
Perfect. Yeah, I look forward to seeing how, others develop these techniques and hopefully improve upon some of the risk benefit ratios that we've presented here. And ultimately, as we said, the paper has a really nice algorithm that goes through, both clinical and other factors for choosing each of the techniques, and also has pictures of each technique, importantly. So certainly we encourage people to be able to review the actual paper to see those pictures.
Can I ask each of you a question now? I'd be interested to know, were there any surprises that you came across when you were researching? Obviously we went through, I don't know, 100 plus papers as we were doing this. Do you guys recall off the top any surprises about Eric arch bars, about IMF screws, about hybrid systems, embrasure wires, or dental occlusion ties?
I'm with you, Scott. I was most surprised about the high tooth root injury. That was much higher than I think I really fully realized. I think we talk about that option a lot, but in terms of seeing how prevalent it truly is with some of the screw-based technologies, as you say, it's definitely something to be very aware of, and even make sure you're evaluating your patients for afterwards. And then the other surprise to me was just that how high the risk of the needle stick injuries and wire stick injuries truly are with the wire-based technologies. So I think both those things that, I'm considering a lot more in my practice in terms of when I'm choosing one or the other.
Yeah. Yeah, to get specific, the rate of tooth root injury is over 10%, like 12.5%, I think is what was published in one study with any of the screw-based systems. And the glove puncture rate, which doesn't necessarily equate to skin puncture rate, but the glove puncture rate was 50%
Yes.
in a trial that was performed. So I guess that's motivation, especially as a lot of otolaryngologists don't double glove for surgeries. That's probably a really good reason to double glove.
Mm-hmm.
It's interesting you say that, Scott, because I've only recently committed to double gloving in any trauma, and it's a consequence of this experience. I would definitely second the other things you said about the tooth root injury. As an engineer, I was an engineer before coming into medicine. I'm most surprised by the longevity of Eric arch bars. And I'm still using them. There's still plenty of cases where it is clearly the best option. And anytime you have an invention that spans what's going on 80 years now of it still being a very relevant technology, that's impressive to me. That said, the other surprise is that there's really been this explosion of different options over the last decade. And so I still think it speaks to the fact that there's a lot to be desired. And I'm glad that we have these new options, because I do think that with a good knowledge base, you can really decrease the risks, increase the comfort for the patient, and give the patient a better experience.
Yeah, I totally agree. I was actually reassured. I remember I'm actually looking at the chart right now, table 2 in our paper, about the different techniques. And I was actually reassured to see that it takes other people are willing to publish that it takes them up to 95 minutes to apply Eric arch bars in complicated situations, because it always takes me longer than I think it should. So I think that, and then shared with you guys some of the other things that surprise me. It's great points, Alan. Like when we have patients that have good occlusion, we don't want, good baseline occlusion and minimally displaced fractures. We don't want our treatment to be more damaging than their underlying injury is, right? And so choosing an appropriate technique for establishing maxillomandibular fixation while minimizing risk to their long-term health, dentition, and occlusion, I think is a critical factor. So good. Yeah, it's been a pleasure working with you guys on this. Thanks for sharing those insights, observations, and learning points.
Perfect. And yeah, hopefully others will find this a beneficial review of maxillomandibular fixation techniques.
We'd like to thank the authors for their commentary, and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.